Welcome, everybody, to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic is the good, the bad, and the orals, an oral pharmacology course delivered by Dr. Walt Whitley, who serves as Director of Professional Relations Education at Virginia Eye Consultants in Norfolk, Virginia, and a Regional Medical Director of Eye Care Partners. His practice encompasses ocular surface disease, glaucoma, surgical co-management, and clinical research. He's a nationally recognized author and lecturer, has given over 1,500 presentations on disease and co-management. He serves as co-chief medical editor for Modern Optometry, a contributing editor for Review of Optometry, and co-medical editor for Dry Eye Coach. He's a past chair of the American Academy of Optometry anterior segment section, past president of the Virginia Optometric Association, where he's recognized as the 2012 Young Optometrist of the Year, the 2015 Legislative Key Person of the Year, and 2020 Optometrist of the Year. We're very fortunate to have him here, so I'm looking forward to an excellent educational session. So with that, welcome, Walt, and take it away.
Well, hey, thank you so much, guys. Hey, thanks for the great introduction there, Joe and Greg, and I appreciate the opportunity to be here with all of you. Anytime I get to present a lecture with my co-moderators that who are mentors and we just have great discussions on these calls, it makes it a great learning experience, and so looking forward to tonight. As you know, oral medication, we've all prescribed it, we've all taken it. This is going to be a review course. But what we're going to do is we're going to go through various case presentations and, just think about where do these medications fit in? How do we choose the various medications? What are the side effects? What are the considerations we need to do or need to take for those patients? Is it a side effect the patient has, or are they having an allergy? And how can we increase compliance for our patients? And that's just for the drugs that we are prescribing. As the bad, we know that many of the medications do have, once again, side effects, and any oral medication patient may have ocular manifestations. And so toward the end of this lecture, the last 20, 30 minutes, we're going to talk more about systemic medications that we have to monitor, or if we see certain ocular manifestations, then those are patients we need to discuss and collaborate with the prescribing doctor and let them know what our findings are and what we need to do about it. Well, if we look at the data, 80% of patients take a prescription medication, over-the-counter medication, or some type of dietary nutritional supplement that they may take. 82% of those patients take at least one medication. Up to 50% of patients take 3 to 4 medications. And about a third of our patients take 8 or more medications prescribed by 3 or more prescribers and different doctors. And so that's why, just like within eye care, we're the quarterback of our patients' care. We need to make sure that we are communicating with their primary care provider and their specialists, letting them know, what our findings are and some of the things that we are doing or they are doing that can affect our patients. But communication is key to successful co-management, and I promise I won't take any longer on one slide. Here's my disclosures. I do work for several companies for this, not many for this presentation. And so here's a case where I was sitting in between patients, and I'm on doing emails, and my scribe comes in. She goes, "Hey, Dr. Whitley, you got to come quick. There's this patient with blood on their face." I said, "What are you talking about?" They have a subconchine. Nobody has blood on their face. She goes, "No, seriously, it's blood on their face." And said, "Okay, well, let's go take a look." So I walk in, and this is what I see. So the patient actually did have blood on their face. So 82-year-old white male, we're going to ask the questions, what happened? Well, I don't know. I woke up in the morning, I had blood all over my pillow, and I had blood on my face. And I said, "Okay, well, what happened last night when you were sleeping? Did your wife punch you? Did you get in a fight?" He said, "No, I sleep alone." I said, "Well, what about do you sleep with your dog? Did your dog scratch you?" "No, nothing." And then going, "Well, something happened last night and you're not remembering, but whatever, we'll keep going. Maybe you were coughing, sneezing. They weren't heavy lifting because they were sleeping, but somehow they rubbed the heck out of their eye. And what do we see here? We see a huge subconcheme. We see a conjunctival laceration We have no idea how it got there. Ask him about blood thinners, and he says, no, I'm not on any blood thinners as well. And I said, okay, well, we'll just keep going and review his medications and his history. So we take the vital sign of the eye, the visual acuity, and the vision's fine, maybe 20/25, 20/30, had mild cataracts. And then, of course, we're doing all our entrance skills, and we want to get to this eye. And so before we do anything, yes, we see the blood on the face, we get behind the slit lamp. We want to make sure that we have a formed anterior chamber, because if it's flat, then we're worried about an open globe. So we knew it was formed. And so I didn't take pressure yet. I wanted to play with this area. So I got my cotton swabs and playing with it and getting my fluorescein strips to see, is there any open globe? Do we have a positive Seidel? And we didn't. We just had blood on the face and on the eye. And so then I knew I could check the pressures. Pressures were fine. So the question is, what do we do? We have this case, and of course, I'm in a satellite clinic about 40 minutes away from all of our cornea specialists or any of our surgeons at 5 o'clock on a Friday night. And so the patient's like, I said, hey, I should send you to see one of our docs. He goes, no, I'm not going. And I said, okay. Long story short, I said, this is what we're going to do. Or think about, what would you do? And so something like this, it's not an open globe. And so this is where we use a pressure patch, and that's underutilized within eye care. I know, Joe, you wrote an article about this, conjunctival lacerations. And so I did a pressure patch. I put bacitracin in the eye. And I told the patient, I said, hey, we're going to do the pressure patch, put the goo in there, close the eye, put the gauze on, put the shield on, and then said to come back tomorrow. And that's where the good news is. I have residents that came in the next day. And I said, well, if there's any bleeding still, then we have to get the on-call surgeon to put some conjunctival sutures inside that laceration. Patient came back next day. It wasn't bleeding anymore, so we didn't have to do sutures. And actually, working within a cornea practice, I've rarely had to do conjunctival, refer for conjunctival suturing. What about you guys? Have you ever had to do that?
No, generally, I have not. If I had a really, really bad laceration, we've got some corneal surgeons that can help out.
Yeah.
But for the most part, the conj is pretty resilient. Clean it out. Most of these come with dirt in it because it was a palm frond or something like that. So you got to lavage it out. You got to clean it out. Get as much, put the ointment in there. Slap the tissue together as close as you can, and maybe patch the eye and then see what happens. But this person's not telling you something.
Yeah, and when he didn't tell me he was taking Plavix. Okay, well that accounts for the blood, but you must have scratched the heck out of your eye, because I have no other reason why this would happen. And so this case is just one of those cases. Sometimes the patient does not tell us the medications they're on, and so it's important to keep asking the question. There's something they're not telling me. So you hit the nail on the head there.
Well, not just even the Plavix, but it's not telling. This person probably knows. This is not your typical subcon gene. You've got a laceration. It just doesn't pop.
Yeah. Thankfully, it all got better, and so, but this was a side effect of one of the medications that did contribute to that. And so, which orals do you commonly prescribe? And there's a lot of different oral medications, and we all may have prescribed some today. I know I prescribed diflucan today for a patient, several antibiotics, Bactrim for some patients as well for a preseptal cellulitis. But whenever we're prescribing, what is the indication, whether this is oral, whether this is topical, what are we prescribing for? Is it brand versus generic? And since it's an oral lecture, we know when it comes to brand versus generics, if we want to look at equivalency, we can draw the blood and see, what's in there. Does the insurance cover the prescriptions? Normally with oral medications, normally there's many generics out there that we can reduce the cost for our patients. And then whenever prescribing, compliance is going to be the key. Less is more, because the more we prescribe for a patient, the less that they're going to do the medications. And so classic example is a patient that has herpes, right? And let's say keratitis. And so we prescribe the medication. We know within the boards, the answer is 400 milligrams 5 times a day. However, the more you have to make the patient do it, less they're going to do it. And so, I mean, if you prescribe 800 milligrams 3 times a day, you can have much better compliance for your patient, or switch to a different medication such as valcyclovir, which is 500 milligrams 3 times a day if it's for a patient with herpetic conditions. For any of the medications, for this is more for topical, there's always assistance programs. And so, find out, talk to your colleagues, what are some of the resources in your area. And there's a huge typo here. And so you can just pretend you know what it says, such as adherence. But these are some of the barriers that we have when it comes to adherence in anything we prescribe. Thankfully, once again, the cost of many oral medications are affordable for patients. Just mentioned the confusion and the compliance. But whether it's a drop, whether it's oral medication, can the patient take their medications? And thinking about the different drug delivery systems on how we can get the medication for the patients. Side effects, sometimes if the patient, let's say they take an oral antibiotic and they get a stomach ache, well, we know that that is a side effect of the medication. That's not an allergy. And so something we just need to tell the patient, this is something that you may experience. But then also doctor direction, and tell them, hey, this is the medication. I need you to use it 3 times a day for a week. Oftentimes, if it's antibiotic, I say whatever it is for 10 days. Hopefully they take it 7 days, and the patients are going to drop the last 2, but at least I'll get a full week's worth of therapy for our patients. Review the medical history. Many drugs can affect renal or liver function. Review the current medications that the patient may take, and to make sure there's no contraindications. The side effects versus true allergies. True allergies, we know anaphylaxis, patients get hives, shortness of breath. Pregnancy or nursing or with children, we'll go into that here shortly. And so there are many medications that are okay during pregnancy. We were so excited, my wife and I, to go to the Kelly Clarkson concert. And so in her belly baby, you can see the bottom, Brock and Beckham, and they're at this time. And if any of you have twins, these are the twins that want to be carried at the same with the kids. She got up and picked the kids up, and she heard a pop in her knee, and so she needed knee surgery. And so determining when the appropriate time is for the surgery, what medications that she can take. I think she was maybe in her 3rd trimester. I don't remember at this time. That was many years ago. But either way, there are many you can prescribe. The safe way of prescribing, I typically consult with the OBGYN, just let them know, hey, this is the condition, whether it's a topical oral medication. And if you have any questions, just ask them, what can my patient take for whatever medication? And so here's a list. So whether it's an antibiotic, antiviral, analgesic, allergy, many medications that patients may take. And so for her, she had that surgery, and everything went just fine. So here's our first polling question there, Greg. A child can be dosed as an adult at the age of A, 5 years old, B, 8 years old, C, 12 years old, or D, 18 years of age.
And Walt, as this polling question is going on, you might want to reach out to the kids. You just started to lag. I texted with Joe, and starting to break up, so you might have some the kids on gaming right now.
I think I'll do that real quick.
You might want to just go ahead and mute.
Hey, Brock.
All right, so we have the polling question open. A child can be dosed as an adult at the age of 5, 8, 12, or 18. Which one do you think Walt is going for here? So, all right, looks like we've got a lot of people. Thanks for doing that, Walt.
Well, of course, they said we got teenagers, so they weren't on anything.
All right. All right, so I'm going to display it right now. We have 3% saying 5, and we have 7% saying 8. We have 21% saying 18. Your majority is at 68, 69% now at 12.
Okay, good. So the answer is 12. And so whenever prescribing for kids, we want to know the age, and that's only one variable. Know the weight, 88 pounds or higher. We can prescribe as an adult. If you're not sure what to prescribe, look at the dosage and you can do the math. Much easier to call the pharmacist. If you have any questions, those are the twins, the womb mates when they're younger, so they're older. And Greg, if there's a glitch, just let me know.
We're good. We're good now.
Tetracyclines and fluoroquinolones, we know in kids, discoloration of teeth, tendon rupture that can occur as well with fluoroquinolones. And so just some of the considerations. But thankfully, we have a lot of different medication for prescribing for kids, or call a pediatrician if you have any questions. I have to show the other kid, that's Brady. So I was just at baseball practice with him before that. But I don't do the math. I just call the pharmacist. Actually, I don't really see kids. My youngest kid is like 40. But if I did, I'd call the pharmacist. They can give you bubblegum flavored and just tell them the weight and the age, and they can do that for you.
Well, another little pearl that I've learned from lecturing with Tracy, the pharmacist, too. Sometimes you get, a 10-year-old that comes in as big as a tank or whatever, but 12 is a good number. I totally agree. But you can also check for puberty. If they've gone through puberty, then, it's wide open to go, with an adult dose. So that's another little pearl out there for the audience. So.
Perfect, thanks. And there's many different clinical reference apps, and these are just a few. And, some of our colleagues on the various forums, they have their own as well. And so many resources that are available that give you cost as well. But let's go into some of the cases. And so here's a case: a 34-year-old white female presents with pain and swelling in the right lid and right side of the face. It started about 4 days ago, suddenly not getting any better. Started Augmentin twice a day. I can't remember the doses. I want to say 875. She's 20 weeks pregnant and can only take Tylenol for pain. She had a similar episode a couple years ago prior, which resolved, and her previous prescribing doctor gave her refills, and so she had these medications. Ocular history, epiphora in the right eye. You can see pregnant, otherwise healthy and no allergies. And so taking a look, we can see vision, everything's fine, but you see that swelling, that tenderness. She's in pain in that area and having the tearing. You can see the erythema that she's having, but the eye's white and everything else within the eye looks fine. So going back to this picture, if we take a look at that, what are our diagnoses? Is it chalasia, which we know what that is? Is it dacryocystitis, where it's affecting the drainage? Is it dacryoadenitis, that's affecting the lacrimal gland? Is it septallitis, because we have diffuse swelling? And we have swelling, so it doesn't really matter during our diagnosis, because in many of these, a lot of the treatments are going to be the same. And this is not a polling question, Greg. I was just putting more questions out there. And then also to go with that, which antibiotic would you choose? So she's already on Augmentin, 875 twice a day. So should we change the ciprofloxacin, 500 milligrams, so using one of the big guns? Add erythromycin ointment twice a day. Continue the amoxicillin or Augmentin. Change the azithromycin as directed, or does it really matter? And so essentially, whenever you're having any infection on the eyelids, the most common culprit is going to be gram-positive bacteria. And so staph, and making sure that we have good coverage with any of the antibiotics we had. And, she was on Augmentin, but that was not obviously working for her. She's having a swelling. And so she was trying to get in with our oculoplastic surgeon to help with that tearing. And so I was able to get her in. What I did is I said, hey, just keep on the medication, because there's not much else that I could do at this time. And Greg and Joe, I'd love to hear if you do anything different. But then I sent it to the oculoplastics and essentially just lanced it, kept her on the Augmentin, and then scheduled for a DCR because she's had this history of tearing. And so that's what I did. She was already on the medication. I mean, there's not much else I can do. Anything else you all would have done different on that case?
No, I agree. I agree with you.
Okay. All right.
And I would certainly avoid Cipro as you have up there right now. Cipro is definitely contraindicated for someone that's pregnant. And then everything else is wide open. Azithromycin is fine. Erythromycin and obviously the penicillin and potassium is good for pregnancy, but avoid that Cipro.
Yeah, yeah.
I don't think changing to any other equivalent antibiotic will do much. You know, when you've got a good drug on board and something's not working, you know, we got to consider, you know, you need some secondary treatment like you had said.
Yeah, and then as I mentioned, you know, she started 2 days prior. And many patients are like, oh, why isn't it taking effect? It takes a few days for those antibiotics to fully kick in, and that's why
Yeah.
I just got her into the special sooner than later. We got her for the DC, and she did much better. This is just review augmentin, amoxicillin clavulanate, penicillin-resistant penicillin. You can see, you can read all this. It is bactericidal, so it does kill the bacteria itself. Different dosage, you can do 500 milligrams 3 times a day, but going back, whenever prescribing, less is more. And so twice a day, you're going to get much more compliance with the patient. Can be used with kids in pregnancy, which she was, but as we know, cannot be taken if a penicillin allergy, can have GI upsets, but also liver injury for patients. So one thing I often do is, I didn't do it in this.
Well, before you move on, go back to that real quick, is that you know, a lot of people might think that, hey, that's a penicillin, and you know, amoxicillin, I might get a failure. And the big, huge point I don't want to gloss over on this is the potassium clavuronate. That's what makes it the penicillinase resistant. That potassium clavuronate is more attracted to the penicillinase, which remember that's that beta lactam ring that breaks down that amoxicillin. Penicillinase breaks down that beta lactam ring. So that's why it's important. If you're going to use a penicillin around the eye, penicillin derivative, amoxicillin, ampicillin, make sure potassium clavuronate is on board. That's why, you know, this augmented by the potassium clavuronate works really, really well. I just wanted to throw that out to the audience.
No, that's a great point. Thanks for bringing that up. And that's why I love lecturing with you both, because then you all can bring up whatever I forget to bring up. For most patients, female patients, one of the things I often ask is, do you have a history of yeast infections whenever you're prescribed an antibiotic? If they do, you can prescribe this, diflucan or fluconazole. Essentially, it's a single dose, 150 milligrams once. And so if they have that effect, or they have that, the yeast infection, I'll prescribe that. If they don't want that, then I just tell them to take probiotics or eat lots of yogurt to minimize that. Do y'all prescribe that much for patients, female patients?
I have not. That's, you know, that's why I love taking CE. I really have not done that. I kind of do the same thing you do. You know, you're prone to it. They know how to kind of counteract it in their own kind of way. Whenever I ask them, you know, I do ask, are you prone to yeast infections? And they kind of say, okay, before I do this, they kind of got their regimen going. But I am big on probiotics. You know, we do mess up that gut microbiome anywhere from a week to a year. Everyone's an individual, so there's not an exact number, but I do like the probiotic comment.
Yeah, I agree.
Yeah, well, I do not, because in Florida we actually have a relatively limited oral formulary, and antifungals are not on it.
Oh, okay. Yeah, and you know, a lot of things that we prescribe, you know, it's all based on the state. But thankfully, with the various state associations, you know, we've been able to get orals in all 50 states, and so that's been exciting. Although some states are more limited than others. If you're on the last webinar, the grand rounds, this is a case that's going to be a review. But if you weren't, this is an 82-year-old white male that had a 3-week episode of chronic conjunctivitis. And you can see this mucus that's just sitting on the eye. We've been using lid hygiene and lid scrubs and moxicillin or on-label or off-label, Vigamox. In this case, it wasn't getting any better. And so it was referred to me. And so it was referred to me for cultures. But when I'm culturing, that's fine. I can take my cotton swab and my culture media and it's all in a tube, and you don't want all the mucus. but clean all that off and just swab the conjunctiva, swab the lids, and you can send it out for susceptibility testing. And so that's easy to do. But the question is, what do we do next? Because we have to choose an antibiotic, we have to choose a drug. And so since it's an oral lecture, we're going to choose a drug. And so we are going to switch. I did switch the patient to besofloxacin from moxifloxacin. And the reason for that, it has not been used systemically. It has been susceptible to something that as we see in many of our elderly, that they are MRSA. And so methicillin resistant staph. And so that's what I was thinking in this case, but also prescribing an antibiotic that's susceptible to that. And that's a tetracycline class, which has about a 92% susceptibility. And so tetracyclines or doxycycline, I did 100 milligrams of doxycycline twice a day for 2 weeks. And when I brought him back, I was positive for MRSA and was susceptible to the doxycycline that I prescribed. And so the eyelid cultures, just get that culture media, get that swab and rub along the lids or the conjunctiva. You don't want all the junk on it, but there's various labs in your area where you can send off for susceptibility testing. It was Health Tracks RX, and actually we're not using the Texas one anymore, Joe. We're using the one in Kentucky now because it's closer. But and what was the term you guys use for that?
No, you broke up for a second, Walt. What did you say?
What's the testing you call that? I said, we send it off, for susceptibility and resistance to the lab.
PCR, polymerase chain reaction. We use the same company, but we're also using Louisville, Kentucky.
Yeah, and so they give us every information about the bacteria and every drug and everything else, and so something that you can utilize. Here's an example of the cultural report. This was the one that was positive against MRSA, but it does tell you what antibiotics are resistant to it. Anytime we prescribe treat and follow, good patient care, we can modify treatment, and that's what we would do with this susceptibility testing. And this was when we had a lab within our area that we could do that in, but we don't have that in our area. But if we look at treatments for MRSA, this is an oral lecture once again. And so the tetracycline class, 93% susceptible or sensitive to the tetracycline class. Even bacitracin, that ointment that we very rarely prescribe anymore, still has 63% susceptibility. But you can see, actually Bactrim would be another option that we could prescribe for patients. And so other considerations for patients with MRSA. Bactrim, I'm not going to read all these different slides. These are all in your notes. And so you can see whether it's the mild to moderate or moderate to severe, you can do the higher dose for our patients. And you can read the side effects that can occur. Do y'all have any comments on this? I don't really prescribe Bactrim much for patients. Anything else? I think I'm moving on from antibiotics anyway.
The only comment. Go ahead, Joe.
I don't have a comment. I don't do Bactrim, but when you talk about MRSA, there's a great medicine that we just don't use. I'm not sure if we can even get it any longer. It would be fabulous because there's virtually no resistance to it, and it is MRSA effective. It's chloramphenicol.
Yeah.
Topical chloramphenicol. And we in the U.S. is such a bunch of sissies, based upon a couple cases in the 60s, which were case series not well researched. In Australia, chloramphenicol is over the counter. Mom can walk into a drugstore and pick it up for her kid, and they use it for everything. Mm-hmm. And we're afraid to use it, but if we had it, that would be a potent bug killer. Go ahead, Greg.
Yeah, go to your next slide there, Walt, if you would. Or you were talking about that. So just FYI, Walt has them down there. You see 80 and 400, and then there you'll see Bactrim listed as DS in your electronic health record. You can see it just doubles. It goes to 160 of the trimethoprim and 800 of the sulfa medication. That's the one that's prescribed the most. So if you're going to prescribe this, circle 180 over 800. I think it's twice a day. I'd probably have to look it up. I have my lectures saved, but if I have to go all the way down to that end line, go through penicillin, go through the the macrolides, go through the cephalosporins. Salt is my 4th generation, and then the fluoroquinolones are the 5th. So every so often you do get the penicillin, macrolide, cephalosporin allergy, and this is what I would reach for.
Yeah, great points. Thanks, guys.
Yep.
So in the case, you've got to be kidding me. So 27-year-old white male presents with red, painful, blurry vision in the left eye. Started about 10 days ago after returning from a trip to Italy, taking 500 milligrams of naproxen for the headaches. Health unremarkable because he's 27 and has never been to the doctor. Vision, you can see 20/20 minus, 20/25 minus, pressures are fine. But the patient has mild limbal flush in the right eye, 2+ injection in the left, but you can see bilateral inflammation. And so I'm asking questions. Have you ever had this before? No, I've never had this before. Any back pain, joint pain, any other pains? No, I just had a headache and my eyes have been red and my left eye is blurry. And so we know that, anytime patients have uveitis, that we always need to consider, is this idiopathic or is there something else going on? And so question for you two is, would you all, first episode, you denied everything. Does lab testing, is that required in a case like this?
I'm so on it. I mean, the fact that it's bilateral is a bit concerning. I would be torn as to whether I would do it, or more likely in the healthcare system around where I practice, I would try to get him into a rheumatologist for an evaluation. Now, the challenge is where I am, getting into doctors is really tough.
Yeah.
Sometimes I have a hard time finding neurosurgeons to take out brain tumors for me.
Yeah.
So it behooves one to have, a relationship with specialists so that at least they recognize your name. You can help bully them onto a schedule.
Yep.
And sometimes it involves picking up a phone and speaking to the front desk at a rheumatologist's office. I probably would not run the tests myself in this situation. I would probably, if I did it, I would do it through a rheumatologist, but I'm only 50-50 that I would do it.
Okay. Greg?
Yeah, I'm kind of mix. I do probably now in this case at 27, I'd probably be 50% doing it myself, maybe looking, then trying to figure out where to go. I maybe would refer it to, I do have a rheumatology friend like Joe was mentioning that I can kind of bully my way in. It would probably be on other symptoms too. If I was gonna lean on this, a 27-year-old, if it's raging, maybe an HLA-B27, it may be one of those type of conditions going on in a younger age. But it's probably be more based on if how angry the eye was. Is there mutton fat? We certainly know that that the immune system has, the eye has immune priority, and it's been broken. So we definitely have to be concerned about it.
And, I left that out, is it non-granulomatous? Is it granulomatous? If it's granulomatous, we're thinking more it's systemic in nature. So look, anytime we're looking at this, well, it doesn't come out very well. So the right eye, that's 1+ cell because you can't see the cells. So I've learned how to, through PowerPoint, to add cells. And the left eye, you can see there's about 2+ cells. And if we look at the standardization of uveitic nomenclature working group, less than 15 cells is going to be grade 1, so 5 to 15. 15 to 25 is grade 2. 25 to 50 is grade 3. And anything above that is going to be 4+ cellular reaction. So this was bilateral. What is your treatment? I'm not going to go into all these drugs just because we know that that the patient needs a steroid. My partner, John Shepard, he's a uveitis specialist. I've been working with him for about 16 years now. So I've learned a lot I've seen lots of uveitis with him. And so typically we'll prescribe difluprednate, which is 4 to 5 times more potent than brand Pred Forte. Yes, we know that there may be pressure spikes that occur with that, but we know if the pressure goes up, treat the pressure. So switch to a different steroid, loteprednol, put them on a glaucoma medication. But the sequelae of inflammation is a lot worse than the pressure itself. But don't forget, anytime you're prescribing a steroid, that you always want to check the pressure. I think it was 10 and 11 or something. I don't remember, 9 and 10.
9
And
and 10.
also check the nerve for those patients, because if anyone's going to be a steroid responder, that's going to be a glaucoma patient. Prescribe a cycloplegia, it's going to help with any of the eye pain, but doing the dilation, anytime we're having that inflammation, we want to say in uveitis, we want to see, is there any posterior involvement? Because the more posterior the inflammation, more likely there is a underlying cause, and most likely it's an infectious etiology. Toxoplasmosis is the most common for the posterior uveitis. The differential for anterior, the symptoms are the pain and light sensitivity. For posterior uveitis, it's to be blurred vision, and floaters are typically the symptoms there. So prescribe a cycloplegia, or typically what I do is I just put an atropine in the office. I dilate them and I atropine. I had a patient yesterday that had the worst corneal ulcer ever. And so cultured that, but he was in pain. So I just put a drop of atropine in his eye because I know if I prescribe cyclogel for that patient, it's not even held at the pharmacy anymore. But then would you consider lab testing and, having those resources that the doc just mentioned that you can go to say, hey, what are your thoughts on this case? But since this is an oral lecture, would you prescribe an oral medication? I'm going to say yes, because this is an oral lecture. And so this was an acute bilateral non-granulomatous anterior uveitis, both eyes. Cause, who knows? Treatment, that's what I did. And then cyclopentolate at that time, this was years ago, 3 times a day in both eyes. But this was a case where I ended up ordering lab testing, and I'll show you why shortly. Anytime you have uveitis, hit it hard. Don't taper any steroid until you get 2 grades improvement in inflammation. And that's going to be key, because if you taper it too soon, those are the inflammatory conditions that are going to linger for our patients. In this case, so yeah, this was 9 years ago, ordering the various tests, knowing he's 27. Greg mentioned HLA-B27, ACE, that's not really likely going to be him for sarcoid. Rheumatoid factor, ANA is very non-specific, but did the syphilis testing as well, and PPD and chest x-ray. We've updated our lab testing, and I'm happy to email this to you. We have all the different ICD-10s and all the most recent labs, as well as imaging if needed for our patients. And so I order the labs, and of course, what comes positive is syphilis. And so we know there's different screening tests. We have the VDRL as well as the RPR. And so this is going to give us our titers to see how much of the organism is within the body itself. We know the FDA ABS, this will be positive for life for patients, and it's reactive in primary, secondary, as well as latent syphilis for the patient. And so that's essentially what he had. You can read this case. Treatment here is penicillin therapy. But if you recall, he has a penicillin allergy. And so we have this diagnosis, you get the labs, and so you have 2 choices. You call the patient, since you ordered the blood work, and say, hey, this is what I found. If not, the health department is going to call the patient and say, this is what your doctor found on the blood work. And so I called the patient. He said, you got to be kidding me. And either way, I said, hey, yeah, you have syphilis. And so I need you to go to your primary care or urgent care, and they can give you the IM injection of penicillin G. Well, if you didn't have a penicillin allergy, but they need to give you something else. I let them know that the urgent care, primary care is treating the syphilis. I'm treating the inflammation for the eyes. And so that's where he says, you've got to be kidding me. He does have an allergy to penicillin. And so here's a study. It's an older study, but there are other antibiotics that are susceptible to syphilis and to the organism. And so other options, and he did get better over time. And so the patient was prescribed doxycycline in this case, 100 milligrams. With syphilis, anytime it affects the eye, that is actually neurosyphilis. And so instead of the patient being on the oral medication for a couple of weeks, typically they're going to be on it for maybe 3 to 4 weeks until we get full control of the microorganism. and that's going to be tested with the various blood work and titers. And so another question, this is a polling question, not a random Whitley question, Greg. Side effects of doxycycline include all the following except A, GI upset, B, light sensitivity, C, pseudotumor cerebri, or D, dry eye.
So
Fantastic.
interesting.
Polling question. is
Well,
open.
that sounds like he had a really good trip to Italy.
That's funny you said that because Eric Schmidt
You know, I've always said exotic lifestyles lead to exotic conjunctivitis. But you know, you're talking about just going back to the difluprednate and the pressure elevation. Interesting. I'll give it a little bit of a clinical pearl. Back when difluprednate, Durezol was relatively new, you know, we started seeing the pressure spikes. They happen a little quicker, they happen a little more exaggerated. And you're right, you use the drug, but you treat the pressure. But there were a lot of reports, case series, anecdotal reports, and a paper came out. It was in the optometric literature. I don't remember who the author was, but they're optometrists, and it was a really good paper. And they actually did like a meta-analysis and looked at all these reports. And what they found, and I was embarrassed to say that one of the reports they looked at was one of my publications, that the patients who seem to get into trouble with pressure are the ones who are overprescribed the medicine. When we treat Durezol like Pred and prescribe it every hour to 2 hours, they're the ones more likely to have the pressure response. But if you stick to a 3 to 4 time dosing, even if it's bad inflammation, if you're going to trust the drug that it truly is as strong as it purports to be, stick it 4 times a day. I think that you'll have much less of a risk of pressure elevation.
Well, you got a good response to your polling question. We have 8% saying GI upset, light sensitivity, 4%, pseudotumor cerebri just went to 17%, and dry eye 71%.
All right. And so the answer is, you can see on the bottom there. And so doxycycline, we prescribe this quite often. And, for me, typically I'm doing it for dry eye and MGD, but I'm not doing it as often as I did before. Most commonly for me, if it's a patient with internal hordeolum or external hordeolum, that's where I'm taking doxycycline, as as long as there's no contraindications for the patient. Also, whenever it's a hordeolum, one of the things that we're finding highly associated with this is Demodex. And so we do have topical medications such as topical lotilaner that's twice a day for 6 weeks that I've also been prescribing for patients with chalasia because patients don't like it. They don't like that ugly bump on their eye. They want to do anything to prevent it. And so it's not on label for chalasia or hordeola, but it is treating the Demodex that may be associated with that. So it is off-label use. Inhibit bacterial protein synthesis. We know cannot be used in kids in pregnancy, as was mentioned earlier. Various doses, the anti-infective dose was used in longer in this case, 100 milligrams twice a day for several weeks versus 10 days. If it's a anti-inflammatory dose, typically I'll do 100 milligrams, once a day for a couple months. The most I keep the patient on is about 3 months, but those are the side effects: GI upset, photosensitivity, and pseudotumor. Areas where we may consider prescribing.
Well, go ahead, go back. I know you're on a roll there, but go back for a second.
Okay.
I just want to chat about doxycycline here, and think of this as aspirin. Is that if you give aspirin at low dose, you get antiplatelet, and as you give it higher, you get more antiplatelet. You get analgesic, then you get anti-inflammatory at a higher dose. And just remember that's the same thing with doxycycline here. Lower dose, 40 milligrams, you're getting an anti-inflammatory. It's anti-collagenous. It has anti-proteinase activity, and it's also MMP9. Low dose anti-inflammatory, that 50 milligrams twice a day. Higher dose, that's at 100 milligrams, and then twice a day. That's what you're using for your MRSAs and for your Lyme disease, and that's where you're getting that bacterial protein synthesis that inhibits that's out there. So just remember, as you give different medications at different strengths, you get different, you get different outcomes, I guess, or different performances of the medication.
Yeah, great point. So areas where we may want to consider using doxycycline. So here's a patient that complains of when they wake up in the morning that their eyes are in pain. And then by the time the patient comes to you, you're not seeing anything on their eyes. And so here, this is Brian Kim. He's an ophthalmologist. Can't remember where he's at, but this is called the Corneal Kim Suite. So anesthetic works better here because then you can at least touch the eye. But you can see right there the little micro abrasion that the patient may have, where you saw those little irregularities with an epithelium just in that area. And he's going to look at other areas that the patient may have this. And so these are small micro abrasions. And so recurrent corneal erosions that the patient may have. It's not the large one that by the time they show up, we see the sloughed off cornea. Here in a second at 10 o'clock, you're going to see him, Brian, rub that area, and you're going to see more loose epithelium. And so in this case right there, and so this is a case where a patient would be a candidate for something such as a superficial keratectomy. In this case, doxycycline would be a great option because as Greg mentioned, it's a collagenase inhibitor, but it also has the anti-inflammatory and addresses the MMP9s. And so it is very useful in addressing any corneal conditions, whether it's this, whether it's a corneal abrasion, or even a chemical burn is somewhere where doxycycline can play a role for our patients. And so there's doxycycline, and we can go into the hyclate, the monohydrate. The hyclate is more soluble. The monohydrate is less soluble, has less GI upset that the patient may have. And we all have our favorites. For me, unless I don't really think of it, I don't really look into it as much, because in the end, in my experience, they both work the same. We're treating an infection, we're treating anti-inflammatory. I know Greg or Joe's going to disagree with me on something there, but I really don't differentiate between the two. Greg?
I am certainly not going to disagree. I'm going to agree with you is that it makes no difference. I think of it kind of as a vodka drink. If you want your vodka in ginger beer, if you want it in orange juice or cranberry juice, the delivery system doesn't matter. It's all about the vodka. So it doesn't really matter if it's hemihydrate or monohydrate. It's the doxycycline. It's just a delivery mechanism. There might be some things that you said, differences, solubility, blah, 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 but it doesn't matter.
I'm in agreement. One thing I learned from Greg is if I write down hyclate, I prescribe it because it's in my electronic record. I'll put on the note to the pharmacist, monohydrate acceptable. That gives them the option that if one is not available, they can just swap it over without any issues.
Yeah. Great points. And other options we have is azithromycin. And so it does also inhibit bacterial protein synthesis. Going back to compliance, this is as easy as it gets. 500 milligrams on day 1, and then 250 milligrams day 2 to 5, or you can do a 1 gram dose if the patient has chlamydia. Pregnancy category B, you can see the side effects here, but making sure we're asking the patients, do they have any heart issues, any arrhythmias, because that does affect the QT interval. And so if they do have those heart issues, this is not going to be the best option. It is losing its effectivity against gram-positive and gram-negative. It is a broad spectrum, but it does also have great anti-inflammatory properties. Typically, if I'm treating an infection, this is probably the last one I'm using, but I do use it in place of doxycycline for MGD or some of the lid conditions because of the anti-inflammatory properties. I'm going to show you this study. This was published several years ago, but comparing for dry eye, where we're using it often, in patients who fail to conservative management with at-home therapies and artificial tears. There's about 110 patients in the study, and the patients were either on 100 milligrams of doxycycline twice a day or 1 course of oral azithromycin. And what they found is a 5-day course. They looked at the patient at 4 weeks and 6 weeks or 8 weeks. But either way, 5-day oral azithromycin is recommended for its better effect on improving the signs, better overall clinical response, and shorter duration of treatment for patients. And so this may be somewhere we may want to consider it. I'm going to skip the study on top. It's about topical azithromycin that's in the clinical research right now. But on bottom, this is the most recent study looking at post-oral azithromycin versus a 6-week oral doxycycline for moderate to severe MGD. The post-oral azithromycin was 1 Z-Pack a week for 3 weeks versus 6-week course of oral doxycycline, 100 milligrams twice a day. And I want to say there was 130, 140 patients in the study. And what they found, they were very similar in outcomes for both of those conditions. And so, so you can use either. Do you all have any comments when you use a Z-Pack for patients?
My 2 comments would be when a patient is penicillin sensitive, it's the drug of choice for penicillin sensitive patients.
Yep.
And remember that a 5-day dose can last up to 15 days. It's a rare, but up to 15 days, but it's usually 10 days that it can last. A 5-day dose usually lasts 10 days. It's been shown to be in the body for 15.
Yeah, for me, prescribing a Z-Pack is somewhat complicated. My electronic health record doesn't actually allow for it. So I actually have to kind of write that out and hope that the pharmacist can figure out, I just can't write Z-Pack. It just doesn't work in my system. But for MGD, I like using azithromycin. A study was out within the last several months. What I like to do is 1 gram through once a week for 3 weeks, 6 pills.
Yeah. Yeah.
500 milligrams, or I should say 500 milligrams, two pills once a week for 3 weeks. And it works very well. And I also use that for rosacea patients.
Okay. Awesome. Awesome. Thanks for those pearls, guys. So our use for antibiotics, actually, we have a lot to talk about, so I'm going to go through this fast. Orbital blowout fractures is someplace where we would prescribe, and this is my partner, Tom Jolie, one of their patients. Here you can see that air bubble inferior to the orbital floor. And so this is
pointed out. Well, your pointer will show up.
Oh.
If you have it. There you go.
Yeah, so right in here. And so the patient has a blowout fracture. We know something hit the eye. But in this case, when do we do something? Many times the blowout fractures go to the urgent care or the ERs, and they're going to do the various scans. But when do we need the patient and let the patient know they may need it repaired? If they have symptomatic diplopia within primary gaze, if they have 50% or more of the orbital floor blown out, or 2 millimeters or more of ophthalmos, those are patients that are going to be treated sooner, within 2 weeks. Anything outside of that, they may just monitor and may improve on it. So in children, it's going to be different. And so with children, they can get that trapdoor phenomena, where essentially with the deficient immune system, that the muscles can get trapped within that orbital fracture. And so the evaluation will be within earlier. But the reason why I bring this up is this is a case where we prescribe Keflex for the patient. Cephalexin can be used with penicillin allergy. You could read this here. In regards to antibiotic sensitivity, because whenever we think of penicillin allergy, we're always told cephalosporin class, there's going to be cross sensitivity. However, that's going to be very low, and that's what this study shows. As you know, within the cephalosporin class, there's 4 different generations. So the higher generation you go, you lose gram positive, but you gain gram negative. And so 3rd or 4th generation cephalosporins, it has a negligible risk for cross sensitivity. So that's a case where Keflex is a workhorse for lid infections or orbital fractures. Here's a case, I'm not going to go in the whole thing, but this patient had a PK, hit his head, opened up his globe. We had to get this repaired. Anytime you have this, you want to call your specialist, refer it to whoever you do. But don't manipulate the eye. Don't put drops in there. Put a Fox shield, put a pot or a pan, anything over the eye so you're not manipulating it. But this is a case for an open globe where here, there's your pot that you could use. But this is where we use a broad spectrum. And one of the big bets, the levofloxacin, 500 milligrams once a day for a week, as long as there's no contraindications, because sight-threatening conditions such as an open globe is where we would consider using any of the fluoroquinolones. I'm going to move over to the virals. and the viruses. So here's our next polling question, Greg. According to HEADS 2, which of the following is an appropriate regimen to prevent recurrent herpetic simplex HSV? A, valacyclovir 250 milligrams once a day, valacyclovir 500 milligrams twice a day, acyclovir 400 milligrams twice a day, or D, acyclovir 800 milligrams twice a day.
While those answers are coming in, I didn't want to disrupt your rhythm, but I just want to talk. You don't have to go. You don't have to move or go back. But the case of the recurrent corneal erosion, I just want to share a clinical pearl with the audience. I do a lot of work as medical malpractice expert witness. Got a case going right now, and we always hear when they have pain upon awakening. We always think recurrent corneal erosion, but it's important to ask the patient: did you wake up and then you suddenly had pain, or did the pain wake you up? If it's the first, it's a recurrent corneal erosion. If it's the second, it's a corneal infection. And it's been breeding overnight, and now you have a lot of inflammation and pain. So that's really kind of, I always try to give that as an appropriate pearl.
Well, that's a great one.
All right, your poll is up and running, and I'm going to display the results. I'm not going to close the question quite yet, but it's pretty mixed, Walt. We have 21% with acyclovir, valacyclovir 250. We have 33% of valacyclovir 500. The 400 acyclovir is at 30%, and 800 twice a day D at 16%. So pretty well split right down all four of them.
Yeah, and so the herpetic eye disease study, and thanks for participating in that. Herpetic eye disease study, first we know oral antivirals inhibit viral DNA polymerase without inhibiting normal cellular activity. You can read all this slide. Actually, about 72 hours. If the patient presents after that, if it's a virus, you're still going to prescribe it. The only time we're going to have caution with the patient and is whether they have any renal conditions, then we're going to want to contact a nephrologist. They have their own calculations about the appropriate amount of antivirals to give the patient. But here you can see the herpes simplex and herpes zoster. If it's simplex, it's going to be the doses in the middle or on the left side. Zoster is going to be double the dose, but remembering less is more. I mentioned if we're prescribing oral acyclovir when we started for a patient with herpes simplex virus, we do 800 milligrams 3 times a day for a week, if not longer, for patients. I went out of turn here, but zoster, we know the symptoms for zoster. Patients may have the vesicles. They have the Hutchinson side on the nose. We know 70% are associated with or do have ophthalmic involvement. When we all get those referrals from the primary care, oh, they have zoster. Well, if they have zoster, well, you know, what we teach our residents and students is, yeah, we know they have the lesions. We're going to, yes, look at the lid. We're going to look at the cornea. Typically, these are going to be pseudodendrites that are not excavated. It's going to be more elevated than anything else. So the fluorescein is not going to pool. But we want to look at the inflammation. Is there any correct precipitates? Is there uveitis? Are there any signs of synechiae? What's going on in the posterior segment? Is there any optic nerve inflammation or vasculitis or macular edema? And so dilating the patient, we do take a look in those cases and then monitoring those patients and treating accordingly. One thing that is something we discuss with our patients is the vaccines for herpes zoster. It is indicated for the prevention of herpes zoster in adults over the age of 50. 2 IM doses at baseline and 2 to 6 months later. But depending on the age, it reduces the risk of developing herpes zoster for patients 50 to 70 by up to 97%, or patients over 70 by about 85%. But we know zoster is part of it. But what's more even devastating is the post-herpetic neuralgia that our patients may have. They're complaining about this chronic pain, the sensation that won't go away. But the efficacy against post-herpetic neuralgia is 85%. So discussions I do have with my patients that are over 50. But going back to the polling question, herpetic eye disease study, I'm just going to highlight the biggest parts here. Herpes simplex virus, iridocyclitis, receiving topical steroids. The trend in the study our trend in the results suggests a benefit of adding oral acyclovir, so 500 milligrams 5 times a day. But the acyclovir prevention trial, it was 400 milligrams twice a day is what was used for the prevention. It reduced by 41% the probability of recurrence, or 50% reduction in the rate of return of the more severe form. So my question for you guys is, we have a patient with herpes, whether it's epithelial, stromal, keratouveitis. When are you prescribing the prevention? Is it after the first episode? Is it after the second episode? Or when does that come in? Because that's actually a good discussion.
I usually do it after the second episode.
Greg?
Yeah, what I usually find it happens is that, like Joe said, I recommend it at the second onset if it's within a year.
Yeah.
If it's beyond a year, then I kind of sit on it and say, okay, let's see what happens. But second chance, second time within 12 months after you fix it, they come back within 12 months. I certainly say, hey, the herpetic eye disease study 2 said there's a 41% drop. We should consider this, put you on 500 milligrams of valacyclovir once a day, or what we can do for the study was, acyclovir twice a day, 400 milligrams. Most of the patients go, well, I'm feeling pretty good that it's not going to come back. It's what I find is usually in the third time that it comes back within a year that they want to go on that. The other one that usually helps tip me over is I just say, are you a cold sore sufferer? They get them in their nose, they get them in the roof of their mouth, they get them on their lip. I can usually say, well, hey, I got a little bonus here for you. If I fix this eye for you, we could probably stop those from occurring. And that's usually like, okay, I get that. It's all connected coming because it's a neuronal virus. That's usually how it plays out. Well,
Yeah, so I get teased a lot for running a herpes clinic. When you work with 4 cornea specialists and their clinics are busy, they come through the ODs first. And, I've been at the practice for about 16 years now. And so if it's epithelial, the recurrence rate is going to be low. I think, 10 years is less than 10% or something like that. Don't quote me on that. Lysogang study, but it was old. It was like in '89. But if the patient has more of the severe form, if it's stromal, and this is what I learned from Shepard over the years, if it's stromal or keratouveitis, even after the first episode, that's when we do offer the oral antiviral in those cases. Switching over to allergic symptoms, now's the time of year being proactive, talking to our patients. Do you have allergies? What are your symptoms? We know that the oral antihistamines do dry the eyes out. And so asking the patient, do you have sinus issues with eyes? If it's just eyes, take them off the oral antihistamines and put them on top of site-specific therapies, such as any of the antibiotic or any of the antihistamines or mass combination drops you want. I'm not going to go over all these. We've all taken one sometime or the other. Here's the various ones out there. I ended up buying the Allegra recently. I didn't realize they were horse pills. I would go with cetirizine every single time. It's a small pill versus those big pills. But the reason why I bring this up is taking a look at the most boring slide ever, is looking at the inflammatory cascade, where all of these medications, the mast cell, we know on the left side, I'll get my pen here, that I just keep moving. But on the left side, it's not working.
you got it.
Okay.
I can see your arrow.
We have a combination of medications here, antihistamines here. We know the NSAIDs work on the cyclooxygenase pathway, but I want to point to this one because what we've learned over the years, and this is anecdotally, I can't report a study, but something else I learned from my external disease partner is using something such as montelukast sodium or Singulair. And so this does have less drying effects on the eye. It is indicated for the relief of symptoms of allergic rhinitis. It's 10 milligrams once a day, and many of the insurances do cover it. And so this is something that you can consider for your patient that have the sinus allergies to cause less drying effects on the eye. And so great anecdotal success.
Hey, well, go back two or three slides. I want to give the audience a clinical pearl there. We had them all listed: Allegra, Zyrtec, and Claritin. One more. One more slide. There you go. What I want to point out to the audience here is that remember that Benadryl, which Walt has there showing, is central acting. It means it crosses the blood-brain barrier. That's what makes us sleepy. These ones here don't cross the blood-brain barrier. Go one more forward, Walt. Right there. That's where he has Zyrtec, your Claritin, and your Allegra. What I want to give to the audience is the strength of these, right? I remember the acronym ZAC, Z-A-C, and that's the strength. Or you can remember Claritin Clear, right? Claritin is the weakest. So Zyrtec is your strongest. Then you have Allegra in the middle, and then you have Claritin or Claritin Clear as your weakest. So if you're going to do step therapy and you're worried about the patient being drowsy and they just have mild allergies, go Claritin. If they're in between, go Allegra and then Zyrtec. Then the next question is I usually get is, where does Xyzal fall into there? Xyzal's kind of a prodrug of Zyrtec, so it kind of falls into that strength of Zyrtec. So Zyrtec, Xyzal, Allegra, Claritin, ZAC. That's the way to remember it. So
Great, Pearl.
okay, that's all I got.
So switching on to oral medications for dry eye, lots of different supplements. I'm not going to go too much into the DREAM study. Most of the clinical studies looking at omega-3s are about 2,000 milligrams of EPA and DHA for patients. They all have various results. There was a prescription medication for hypertriglyceridemia, which is 4 grams of omegas, typically prescribed not by optometrists. And so if you prescribe it, a patient wants a prescription from you, you may get a call from a pharmacist saying, why is an optometrist prescribing it? But tell them it's none of their business. I'm prescribing it for the patient, but it is covered. Oral pilocarpine, that's something that is not used as often as can be. Classic examples of patients who would benefit are those patients that come in holding 2 water bottles, smacking their mouth the whole time, and they have dry eyes. And so we already think the patient has Sjogren's. I had a patient that's tried various medications. Most were not covered by the insurance. Some were. I put her on oral pilocarpine, 5 milligrams, 4 times a day. I told her the side effects. She might drool a lot, may have really sweaty, be a sweaty person, but it's going to work great for your eyes. And so I put her on that, brought her back in a few weeks, and she said, hey, this is the best my eyes have ever felt. This is the best my mouth has ever felt. And so something that you can utilize. Going over the omegas, just briefly, on the right side of this is going to be omega-3s, the EPA and DHA. On the left side, there's the omega-6s. And you're going to hear a lot more companies coming out with supplements that have GLA in it. And so GLA has on the left side, the PGE1, the prostaglandin 1 is a potent anti-inflammatory. The bad omega-6 is the arachidonic acid one. And so that's why omega-6s get the bad rap. And so you're going to see many supplements combining both EPA and DHA along with GLA to get a 2-pronged approach to addressing inflammation and dry eye in patients. So this has nothing to do with omegas. Normally, if you hear me talk about omegas, I don't say omega-3 or omega-6. The supplements I prescribe actually have more GLA than EPA, and I'll show you a paper we published in Cornea. But you may have heard of this, and this was just announced last week. And so this is a combination. This was an initial study that was out of India, and there were about 59 subjects within this study, and they were looking at using a supplement that had lutein, zeaxanthin, curcumin, as well as vitamin D, and it was versus placebo, which is soybean oil, for 8 weeks. What they were looking at is Schirmer scores and all the different dry eyes tests, such as T-BUTS, speed, staining, and tear osmolarity, and you can see the statistical significance off of this pill. And it's 1 pill a day. Many of these are 4 times a day. So this was the first study. And so B&L, this is something that that's part of their formula, or this is their nutraceutical. It's called Blink NutriTears. And when I saw this data, I was like, this is unbelievable data. And so they replicated this study and did this in the US. And there was about 100, 110, 120 patients in the study. And they were able to replicate these same outcomes and with a high statistically significant level. And so I know it's available on Amazon right now. No, I haven't seen any samples, but something that you may want to look into for your patients. But there was no omegas in it, but signs and symptoms this was statistically significant for. Here's a paper we published in Cornea about a decade ago. My partner John Shepard and a couple of my other partners here. This is looking at the GLA formulation, about 14 or 1500 milligrams of GLA and only about 170 milligrams of EPA and DHA. Our endpoints, actually, there are 38 postmenopausal females in this study. And what we were able to do is compare it in statistical significance against a placebo, that it was improving the symptoms of the OSDI, as well as the inflammatory biomarkers of the HLA-DR and the CD11 cell. And so another supplement out there. Here's another one. This is the PRN formulation. They used a more clinical test here, 105 patients. They had about 2,300 milligrams of EPA and DHA, baseline 6 weeks, 12 weeks apart. And what they found, this is effective dry eye treatment with statistical significance, improving tear osmolarity, OSDI, tear film breakup time, and omega levels. So what about krill oil? We've all had that question. Does krill oil work? I'm like, I have no idea with Mega Red. And so here's a study. This was published, 7 years ago. And this was looking at 1,500 milligrams, I think it was sunflower oil, against 1,500 milligrams of fish oil versus krill oil. And it did improve at 60 days for the fish oil, but the krill oil at 90 days did improve the tear osmolarity, which is the salt concentration of the tears. The OSDI, so the symptoms, statistically significant at 90 days as well. But then also looking at the tear film breakup time as early as 60 days and 90 days. And so this does work. I have data for that. I'm going to skip the DREAM study just for the sake of time. Well, actually, I'll briefly talk about it. In the end, prescribe something. This was looking at 3,000 milligrams of EPA and DHA versus olive oil. Olive oil may not have been the best placebo in this case, but both groups did improve. And there's numerous studies showing that nutraceuticals do help for patients, although it did make things very confusing. And that's all I have for dry eye. Any comments? So what do y'all do for nutraceuticals?
Well, let me just make a functional medicine comment. I love, as you know, I think, I moved into that arena the last 5 or 6 years. I want to just kind of feed off of, conventional docs would say, yeah, the omega-6s are bad. Let me come at it from a functional side. The body loves to be in homeostasis. The problem is that our American diet is full of 6s, right? So when we talk about 6s and 3s, they're essential. Essential means we have to eat them. We hardly eat any fish products in America, unless you live down by Joe. I love going to visit Joe because every time we go out to dinner, he takes me to somewhere where I can eat fish. He knows I like to do that. When you live on the coast like that of Sarasota. But the body likes to be balanced out. The 3s balance out the 6s. It's the yin and the yang. It's the homeostasis. So why the 6s get a bad rap is because our diet is full of them and our diet is not full of the 3s. And that's why, in a sense, I take about 3,000 milligrams of fish oil a day that's out there. So I love that you brought that up. And that fish oil is an anti-inflammatory. And I just love doing a comprehensive approach when it comes to an antioxidant. Those are my opinions. So I use the Pharmanex brands, but if we start talking about different brands, we got to start talking about everything due to the COPE rules. So we'll just leave it at that.
Yep.
And of course, Greg, I also make salmon for you when you're down here too.
Oh, it's a good salmon. And I said, Joe, how do you make that? I texted him the one day. So I came close, but could not replicate it.
Before we go on, well, let's get caught up in a couple of questions. Is asked, should you get Shingrix if you never had chicken pox?
That's a great question. If you've never had chickenpox, should you have Shingrix? We're seeing less patients because of the vaccine in regards to chickenpox. I'm going to be honest, I don't know the exact studies, but I do know that it is something that that I still have recommended. I have them talk to their primary care doctor. I'd love to hear what you guys do in that case.
I have had that question come up when I lectured with Tracy Offerdahl, the pharmacist, so I can answer this because I've heard her answer it. Is that the answer is yes, you can do that. And the reason is just kind of like you said, Walt, people might have had vaccines, they might have had the chicken pox and not even known it. But even without that, it's still safe to get it. Because remember, the what was it? Zovirax? What was before that? Not Zovirax. That's
Zostavax.
Zostavax. Thanks. That was the recumbent virus, which means it's kind of dead, weakened. This is not that type of vaccine. So yes, it's safe.
Can you prescribe Zyrtec during the day and Benadryl at bedtime?
Sure.
Oh, yeah, I wouldn't have a problem with it. You know, just you know.
Gosh, this time of year with patients and allergies, we're just trying to survive. I have allergies. I've been taking everything I can just to survive.
Is there a therapeutic difference between fish oil and plant-based DHA fish oil?
Greg, I'll let you take that one. I don't do much with the plant-based ones, so.
Yeah, I mean, they're going down into flaxseed and different things like that. It depends on who you talk to.
Right.
You know, when you go to fish oil, that's from the fish, that when you go to efficacy, that you're going to get a better efficacy out of the fish than you would a plant. So that's out there. So, you know, if you talk to the functional docs, they would rather you get, you know, fish oil, but we do know that there's certain, you know, vegans and vegetarians and different types of the capsule sometimes has the gelatin. So if you're going to do something, then go to plant-based, but most people prefer the true fish oil.
Yeah, actually, you know, talking about flaxseed oil, there's an enzyme called delta-5 desaturase. And so if you're going to take flaxseed oil, you got to take a lot of flaxseed oil because like 85% of what the patient takes gets inactivated by that enzyme. And so they can take, I do, so actually I would recommend it if they can't take anything else, but they just got to take a lot of it. I don't know the amount though.
I think we're good.
All right, thank you. Great questions. And that's why it's awesome having you two on there. So if I don't know the answer, I can just defer to you all. So here's a patient that we can see. She goes, "Hey, this started a couple weeks ago." And I go, "What have you been doing? Any makeups, lotions, whatever?" No. And so we didn't know what we would do here. You know, it's itchy, a little dry. And this is actually at the follow-up, not the initial evaluation. So I'll put her on some combination or a steroid, combination antibiotic steroid because the price is much cheaper. And did that for, you know, twice a day for, I said, 2 weeks and come back. And she came back and was doing much, much better. And then she went out of town or something, forgot it, tried to use it again when she got back, and it wasn't working this time. And the only thing that she said made it tolerable was Vaseline. And so what the next step is, what do? We got to prescribe something. There's got to be some kind of inflammatory process going on. And so I moved her I gave her samples of loteprednol ointment and said, put this on there. And then also I put her on a Medrol dose pack. But when she came back for follow-up a couple of weeks later, she said, no. She goes, I didn't get it. I just didn't feel like taking pills. And so, you know, but I'm trying to figure out how we're going to address this. Since it's an oral lecture, I felt like I'll put a Medrol dose pack when I used that most recently. In the end, you know, we ended up ordering a bunch of blood tests on her and a lot of allergy tests to figure out what was going on with her. And then I just saw her last week. I said, "Oh, I'll see you in a few weeks." She goes, "No, I'm moving to Missouri or Montana or something." So I said, "We'll just find an allergist over there, or a dermatologist to follow up." But eyelids and pain, contact dermatitis, or, you know, we know inflammation is typically inflammation reduced. We know there's many capsaicin receptors within the eyelids itself. The different treatments, you know, with the inflammation in a contact dermatitis, a cold compress is something that would be beneficial for the patient, anti-inflammatory, such as steroid ointment. But if it's not getting better, this is where we can consider first, identify the cause and then treat accordingly. If it's infectious, we see a preceptor, we're gonna prescribe an antibiotic. But if we ruled out the infection, we're just trying to take care of the symptoms, then we're going to treat the inflammation itself. And a Medrol dose pack is something that we may consider. Here's a patient, it's red again, 38-year-old African-American female, presents with red, painful, photophobic left eye, started 3 weeks ago. Her husband's a primary care doctor, and so 10 years ago, he prescribed her dexamethasone, and it worked, but this time it did not work. Vision, you can see 2025, 2020, pressures were 17, and we have all of our various differentials. There was no goopiness coming out. It was just red. She wasn't light sensitive, but she just had that redness in the area. And so thinking, is this episcleritis? Is there scleritis? And so we're going to press on those vessels. Are they movable vessels? We'll use our phenylephrine to determine, does it blanch? And if it blanches, then we're considering episcleritis. But if it doesn't, then we're thinking scleritis. In her case, it did not blanch. And so, no matter the eye condition, when should lab tests be ordered? For bilateral cases, and typically if I have that bilateral uveitis, I've had about 6 episodes of syphilis. Every single time I see it on first episode, and atypical age group, let's say you have inflammation and a uveitis in a young patient, we're thinking about juvenile idiopathic arthritis. If it's recurrent, if it's not getting better, but since it's a scleritis case, we're going to leave it at that. And the reason why we order lab work looking for systemic issues, because 50% of scleritis cases are associated with have some type of systemic involvement. And so the treatment for scleritis, topical NSAIDs or oral NSAIDs, typically we use the oral NSAIDs and we'll do ibuprofen as long as there's no contraindications. We'll do it 4 times a day. And then we'll also use topical steroids, and this is where we use difluprednate because it's 4 to 5 times more potent. And so oral NSAIDs, over the counter, easy to get. You're not going to have the side effects of systemic steroids. And if patients have been on that before, many of them don't want to get back on steroids. So I've never prescribed steroids for scleritis, but that's essentially how we treat that case. Anything different in your guys' case? How you treat that?
I really agree with you about the difluprednate for scleritis. It will do a good job, much better than pred.
Yeah, I agree.
Anytime I have a scleritis, they go to the rheumatologist. There's probably some underlying mechanism.
Yeah, and that's why I want to bring that up. And it's an oral lecture. That's why ibuprofen came in. This is all in your notes. And what time do you want me to start? Because I never finish lectures with y'all because I love the conversation. And
I've got 19 minutes, 9:50 Eastern.
Okay, perfect. Oral anti-inflammatory indications. You can see these all in your notes where we would prescribe those. Here's another patient, 72-year-old white female, sudden vision loss in the right eye. Presents with light perception in the right, 20/50 in the left, APD, constricted inferior visual field, full to finger count, checking the pressures, 18 in both eyes. History, you can see primary open-angle glaucoma, EBMD, pseudophakia, as well as early AMD, and you can see the medical history for this patient as well. Medications are on. She's on Comagan twice in the left eye. Travatan, I should have changed the word. We'll just say it's travoprost in both eyes at night, and using numerous medications, as you can see, systemically. And so take a look at the right eye. You can see that swollen pale disc that the patient may have. The left eye, the disc is more normal is normal in the case. And so the assessment, ischemic optic neuropathy, denied any jaw pain, headaches, shoulder or hip pain, and denied any changes in weight or malaise. And so the plan for this patient, we know because of the age, 82 or higher, we're seeing the swelling, or we already know what our assessment is. And so we're thinking, hey, temporal arteritis, we need to order the blood work, CBC with differential. Is it infectious? Is it inflammatory? Ordering ESR as well as a C-reactive protein for the patient. Or oral prednisolone, asking the weight for the patient. Typically take the weight divided by 2.2 is typically where we start for oral pred. And so for the patient, start on 60 milligrams. I told her, get the lab work first, then start the medication, because if she started the steroids first, then we're not going to have the accurate reading of what those inflammatory levels were. And it said follow up in 1 week pending the lab results. Here you can see the labs, both inflammatory markers were high as well as the platelets. And so we already started on the anti-inflammatory or steroids, but ordered a temporal artery biopsy with my partner, Tom Jolie. And here, I'm not going to go into GCA, or actually, you could read this. This is all in your notes. Made sure the patient knew that her PCP will be monitoring her labs. I'm just monitoring her eye and treating her eye. This is a temporal artery biopsy. If you don't like needles or incisions, you'll want to close your eyes. But this is my partner, Tom Jolie. I asked him for fun videos, and so he sends these to me. And you can see him dissecting down to the temporal artery, removing about a centimeter or two of the artery itself, dissecting it, putting in the culture media or the biopsy kit, and then sending it off to the lab. And this was confirmed for temporal arteritis for the patient. Anytime these incisions are made, it's right at the lash line or the hairline. So the scar that's left will be less noticeable for patients. And so that's the biopsy. We know that there's side effects for oral prednisone, and I'll go through this and then I'll let you all comment on that case with your pearls. Side effects of oral prednisone include all the following except increased IOP, cataract, mood changes, or reduction in blood sugar levels. And Greg will open up the polling.
Poll is open. There was a question that rolled in, and I'll just take it and answer it. It said, does krill oil come from algae? That's, it's a fantastic question because, if you want to go to a high quality kind of fish oil or krill, in my opinion, you want the smallest fish possible. Krill is kind of a shrimp fish, if you want to say creature. It eats the algae, so it eats the algae and then the krill, and then they capture the krill, shrimp, whatever it is, shrimp-like creature, and that's what gets squeezed. You don't want to squeeze the big fish because the big fish, always eat smaller fish and then a bigger fish, and the bigger fish keeps eating, and so on and so forth. And that's where all your lead and mercury, and the mercury, not the lead, but the mercury comes into play from all the pollutants. So a quality fish oil is something, in my opinion, that eats the algae, doesn't really have the mercury in it. Then the fish, whether it's a sardine or an anchovy, eats the algae. The krill eats the algae, converts it over, and then you get a quality fish oil. But krill is from a creature.
Joe, any comments on that case? How you treat that? How you order labs, or who you send the patient to?
Yeah, I see giant cell and temporal arteritis relatively frequently because I've got more patients over the age of 90 than under the age of 23. And our average age is about 65. So I encounter this quite a bit. If there is vision loss, that patient, I'm going to work through the ER. But I'm not just going to send them the ER. I'm going to send them the ER with my recommendations, what my thoughts are. And sometimes I get them from the ER and they kind of want to know what to do. Now, I make sure they all have my cell phone number so I can get the calls. But a person with vision loss already is hand motion or light perception. Our goal is to prevent bilateral blindness. So that's a person that I'm going to work through the ER. They can at least get a SED rate within a couple hours, and they can get the patient on IV. And invariably, when I encounter this, I will get a call from the ER physician, and they'll say, "Okay, the SED rate is 96. What do we do next?" And I will walk them through. They're intelligent. They're well trained, but they're not experienced. They're not confident in the eye. So I tell them, admit the patient, Solumedrol, 250 milligrams every 6 hours. You got to get 12 doses in. After 3 days, you can release them on 80 milligrams of prednisone until they see rheumatology. Then we have to discuss the issue of ultrasound versus biopsy. And if they're in the ER and they're in the hospital, they'll probably get a biopsy. If I'm doing something outpatient where they just have systemic symptoms, I will get an ultrasound. And if they don't have vision loss, but they have systemic symptoms, our goal is prevent vision loss. I will usually work with their PCP and get them on 60 to 80 milligrams until we can get them into rheumatology.
Yeah. So. Greg?
Joe is the expert in the GCA. I follow his lead when it comes to this. Usually when I get these cases rolling in, I phone a friend, text to Joe. Nothing really add really to this GCA. Just anyone 50 and above, you got to think about it.
Yeah, well, that's a great pearl, is utilizing the ER and using the solubedrol, as you just mentioned, Joe. And so that's why, as Greg says, we love doing these, because we learn from each other on ways that we can change.
It's amazing. You know what? One time I had a case come to me. I was like the tiebreak. There was a PCP involved, maybe a neurologist and a rheumatologist. And I got the blood. They didn't seem to know how to get the ultrasound, so I got the ultrasound for him. I remember walking in one day. I was going to call the rheumatologist to give her some information, and there was a message waiting for me, please, with her cell phone, and please call me urgently. I said, I call, and she said, okay, what do we do?
Yeah.
All right, well, let's start on 60 to 80 milligrams, and you can take it from there. She goes, what about tocilizumab? I think it's a good idea.
Yep.
So it helps us to know about it. I don't prescribe the oral steroids. I don't prescribe the IV steroids, but I work with people and they do appreciate the help when you give them the guidance.
Yeah. Agreed. So thank you there for those pearls there, Joe. Prednisone, this is all in your notes. There,
91% got it right there. If you want to say reduction of blood sugar levels.
Yeah.
So.
Yeah, wrong. That's a wrong answer. So, prednisone, you all can read this. We already mentioned AION, scleritis, uveitis. We mentioned that as well. Optic neuritis, that is not. We're going to use oral. We're going to use methylprednisolone IV for 3 days. Then afterwards, we'll go with the oral steroids. Side effects. You can see all the side effects. This is in your notes. But we do know that they do come. The steroids do come with side effects. And so typically we're treating the inflammation. Typically, if we're doing the oral, I'm working with the primary care doctor mostly on that. The short term, the dose packs, you can see the 24 milligrams, 30 to 60. It has that taper on there. And so, for more acute inflammatory conditions, some type of allergic condition. Other cases where I use a dose pack is, let's say you're co-managing a cataract patient. At 1 month, the inflammation is lingering. You keep them on the steroids. 2 months, the inflammation is lingering. That's when I'd consider a dose pack to help resolve the inflammation. But after 2 to 3 months, if that inflammation is not gone, we're going through the history. We do need to consider lab testing. Why does that patient still have inflammation? For the last few minutes, do you want me to stop early for questions, or because once again,
we're kind of doing them. So go for about another 8 minutes, and I'll keep an eye on them, or Joe will keep an eye on them.
Oral analgesics, we know the epidemic, pandemic for the hydrocodone, acetaminophen, or Vicodin, or Lortab, or any of those most frequent prescribed oral medication. I'm pretty sure you've seen one of the Netflix, Hulu, whatever series on the societal issues that we have with abuse of these medications. And so we know, there's a prescription monitoring program as well. The DA number, many of us do have the DA. I'm in the process of, I got a couple of weeks before I have to finish my 8 hours of DA training. But something that we've earned the right to prescribe. And so having that to our disposal is important, practicing at the highest level. Aspirin, we know about this. I'm not going to go over it too much here, or acetaminophen itself. But oral narcotics, we know central acting opioid receptor blockers. It's great for acute pain. And, typically when we're prescribing these, it's going to be for patients that have PRK. And we're going to do it for 3 days max. Or even if the patient comes in with pain, we prescribe 3 days max. For the eye, if it's not better in 3 days, there's something else going on. And so call the primary care, work with pain management or someone else. You can see the onset, peak, as well as duration. various formulations. Actually, Vicoprofen's been pulled. I should probably take that off the slide. But the various dosage there. But typically, write the amount. I write the number. Spell out how many. I say 12. No refills, and send that off for the patient. Although these days, for our PRK patients, and that's where we're using it mostly, we use Ultram or Tramadol, just because it's a non-narcotic for patients. But if you have that patient that has a corneal abrasion or something that you want to prescribe, that's something that you can consider that's a non-narcotic for patients. Moderate to severe pain, pregnancy category C, and here's the side effects that you can see here as well for patients. Do you guys put side effects for pain medications? Nausea, vomiting. You can prescribe Phenergan, 25 milligrams 4 times a day for patients. If they're constipated, they can take sodium duclosate or drink a lot of prune juice to soften things up, or they can sleep off the pain for some patients. Here's the list of many of the side effects of pain. I mean, are you all prescribing pain meds much? I mean, great. You all can do them up in Pennsylvania.
I don't, but the comment that I will make is that one, don't be afraid of them. We're not a part of the pandemic. We're not treating chronic disease. Not to say that someone couldn't get hooked on one treatment, but we're treating acute pain, like Walt said, 3 days. They're probably not going to get the addiction to that. They will get the woohoo effect. It tickles the mu receptor, so that's not a sign of addiction that's out there. So don't be afraid. They're very safe medications. A lot more side effects with ibuprofen than there is with tramadol. If you're going to do pain medication, do tramadol. That's optometry's friend. It's basically 50 milligrams once or twice a day, 3 times a day for the pain that's out there. And if you're going to move on to something else, you can move on. If you have the hydrocodone fix, just do hydrocodone mixed with the Tylenol, 5 milligrams at 300 couple times a day for a couple days, and you'll be set. So tramadol, hydrocodone fixes. Don't be afraid of them. That's out there. Like Walt said, we fought for these. We're not part of the addiction process because we're not treating the chronic pain. We're treating acute pain. Those are my comments.
Yep. Angle closure treatment options, oral lecture. So we're going to just focus on the carbonic anhydrase inhibitors that we have there. We know it's a diuretic, and you could read this. It reduces aqueous formation, decreases pressure about 40 to 60%. Typically what we're going to do, actually we do this every day within our surgery center. And so every patient, as long as there's no contraindication, and this is not for acute glaucoma, but for cataract surgery, we do give that patient 250s after their surgery to decrease any IOP spike after surgery. If a patient comes in with high pressure, typically we want to use the 250s or faster acting. It's going to take about 30 minutes for it to take full effect, but it's something that'll decrease that pressure by 40 to 60%. And then we use our topical medications as well to get that pressure lower until we can get that patient in for a PI with our colleagues. Or if you're in a state that can do the PIs, then you do the PI yourself. Chronic glaucoma, we're going to use the 500 milligram sequels, more sustained release. But then for many of you that, or whenever you see the patient with papilledema or idiopathic intracranial hypertension, that they have the bilateral disc swelling, the female 40, the rest. Yes, we can prescribe the Candy to make them feel better and make everything better. But this is something that we'll typically, I'll refer to neurology, although these days it's so hard, as Joe just mentioned, get into any specialist, especially neurology. And so some of these cases we may have to send to the ER to get the MRI, get neurology involved, get the spinal tap, and then they could do the acetazolamide afterwards. Side effects, contraindications, you can see those there. Just keeping the patient aware, that way they know why they're having those side effects. And there's no way I'm getting into we have time for this part of it. You'll have to bring me back for the ocular side effects lecture down the road there, Greg. But any comments on any of those? for glaucoma, either of you?
Joe, if
No,
you
one-
have
one
one, then
thing-
I'll make a comment. So you go first.
The only comment I would say, if you go back one, the whole pseudotumor thing. Yeah, we need to stay out of that. We are involved in the diagnosis and the follow-up, but that's a brain disease. Diamox is used for glaucoma. That's brain disease. Okay. I have encountered unfortunate situations where some colleagues of ours have looked at it. She's female, she's firm, she's 40, and has bilateral disc edema. And they start treating with Diamox because they could use it, and they don't do the workup. And that's what I call killing patients the old-fashioned way, through misdiagnosis. Because you're female and somewhat over your ideal BMI does not protect you from having a true brain tumor.
Yeah. Excellent point.
My comment would be, and I'm glad you didn't put it on there, is, and it just popped up that if you want to take the survey, it's $9.50. The survey popped up. You'll see survey, little red dot there. Then you won't have to do it after the webinar's over. Is that if a patient is allergic to a sulfa antibiotic, and we talked about one today, Bactrim, if they are allergic to a sulfa antibiotic, that does not mean that they're going to be allergic to Diamox. We do it all the time. I see people with sulfur allergies. They come in. We use Trusoft. We use Cosoft. We use brinzolamide. All these sulfa medications. When people are allergic to the sulfa antibiotic, they're not allergic to the S of it. There's an aryl amine group. That is the antigen. When you move over to acetazolamide or Diamox, it has a aryl amine like-ish group. So there is a very, very, very small chance that they could be allergic to it. But when you move over to like atropine sulfite and all those other sulfates and all that, there is no way that they could be allergic to that group. So just keep in mind, the short of it is, if they're allergic to the antibiotic, they're not going to be allergic to like polytrims and the timolol sulfates and the atropine sulfites and all that stuff. Over on the Diamox side, since you're giving it orally, maybe give a test dose, but there is a very, very small chance that they're going to be allergic to it. If they're allergic to the antibiotic because it doesn't have the aryl amine group, that's what they're allergic to on the antibiotic.
Great pearls as usual, guys. I'm just going to put my email at the end. And so if you have any questions, feel free to reach out to me. I got to learn to get down to 50 or 5 slides with you two so I could finish a lecture, but that'll be next time. So there's my email. If you have any questions, Greg has a handouts for you as well. And thank you all for the opportunity for joining you guys at Optometric Education Consultants. Thank you.
Thank you very much. And don't worry about, never quitting finishing. Better to have too much than have too little. The Rolling Stones don't play every song they know, every show.
Yep.
Go ahead and unshare there, Walt, and I'll share my screen. And thanks everyone for again attending. Right here is where you click the survey. It's the little red dot there. You can take that survey right now. And with that said, I want to thank everyone for attending. Joe, I'll let you look at the last, to make sure there's no questions before we end the CE.
I think there may actually have been a question. Hold on 1 second. I answered one for Deborah about GCA, but Brad just read an article about new test called Reinerson Redline for MGD. Any opinions?
I'm not familiar with that one. I'm going to look it up.
I myself am not either.
I don't know. I'm not sure what. Yeah, I don't know that one either. So sorry about that, Brad. We'll have to look that one up, and we'll probably put it in a lecture somewhere. So. Well, everyone, well, thanks for taking it. That will end the education. Walt, great job. Always love. Oh, I didn't change your slide here. This was the good, the bad. This was your old slide. The good, the bad, the orals. This was a virtual with Walt Whitley. So thanks, Walt, for doing that for us.
Thank you, everyone.